Synchronized coronary sinus retroperfusion is undergoing a multi-center clinical trial in patients being treated by coronary angioplasty. Dr. Kanu Chatterjee is one of the participants in this investigation.
I believe there are enough patients with severe coronary artery stenosis or complex coronary artery lesions where angioplasty itself carries a significant risk of inducing ischemia or infarction and complications. And I believe those are the patients who are really ideal candidates for the use of retroperfusion technique to maintain perfusion of the ischemic myocardium so that effective angioplasty can be performed.
We attempt to determine whether or not retroperfusion is effective in an individual patient by monitoring chest pain, by monitoring a precordial ECG and measuring the ST segment shift during the balloon inflation, and by monitoring regional and global left ventricular function using two-dimensional echocardiography.
As judged by these three criteria, synchronized retroperfusion has been documented to be efficacious in the clinical studies performed to date. The frequency of angina during PTCA was reduced by 50%. Severity was decreased. The time to onset was later in the treated compared to the untreated group. ST segment injury current was less in the treated group. And severe left ventricular wall motion abnormalities were decreased with retroperfusion.
Potential complications with this technique include 1, insertion site hematomas, 2, atrial arrhythmias, and 3, the possibility of causing some bruising at the coronary sinus because of the catheter placement.
One should be looking very carefully the magnitude of increase in pressure in the coronary sinus venous system during diastole. And I personally feel that one should not exceed the pressure more than 40 millimeter mercury. Clearly, it should never exceed 60 millimeter mercury. That is potentially dangerous because there will be potential danger of rupture of the coronary sinus. Furthermore, there might be capillary leak and hemorrhage in the ischemic myocardium.
Despite the theoretical possibility of damage to red cells and platelets with retroperfusion, in our recent animal studies and in all of our clinical studies, we have not encountered this problem.
The contraindications will be when there is no arterial access, like femoral arteries are occluded, the brachial arteries are occluded, you cannot use retroperfusion technique. If there is no easy access to the venous system, like thrombosis of the intrajugular vein or subclavian vein, that will be contraindications for the use of coronary sinus catheter. If the patient already is anticoagulated or has received thrombolytic therapy, then I think one has to be very careful for insertion of coronary sinus venous catheter because any trauma of the coronary sinus venous system may potentially cause bleeding and tamponade.
Like any other new technique, there is a learning curve, and certainly there is a learning curve which has to be reached with arterial blood retroperfusion. However, in our experience, we found that now the coronary sinus catheter can be placed in the majority of patients in less than 5 minutes, and setting up the retroperfusion technique itself takes no more than about 15 minutes.
I believe there are a number of very important future applications of retroperfusion and retroinfusion techniques. Retroperfusion technique will be used in patients with acute ischemic syndrome, such as patients with unstable angina, with recurrent episodes of rest ischemia, patients with evolving infarct. And I also believe the retroinfusion technique will be used to deliver pharmacologic agents such as antiarrhythmic drugs to the ischemic zone, like in patients with severe intractable ventricular tachyarrhythmias.
Elliot, what is the total experience now in man of coronary sinus retroperfusion?
There are 71 cases that have been retroperfused during angioplasty. The results are excellent, as we pointed out. There are very few complications. There are occasional hematomas of the neck, but they've never amounted to anything. But it's amazing that in such a large series, we find it perfectly safe.
Have you had failures of prevention of ischemia in any patients?
No. Almost all the cases had complete relief. Some did not, but that's because of the catheter placement. There's a learning curve there. And now that we've got the bigger pump, we call her Big Bertha, that can deliver so much more blood, we're anticipating will take care of the total heart with this.
Now, in angioplasty, do you advocate the placement of the balloon catheter prophylactically, or should it be on standby but not even inserted?
At our hospital, most of them are on standby. We note that only 2 were mild risks. All the other patients, I think of about 40, were high-risk patients. And the angioplaster wouldn't proceed until that catheter was in place, because he wanted the security to make sure that if something went wrong, he would have the retroperfusion to lean back onto.
Now, we started this program with really a spectacular salvage in the case presented by your colleague, Dr. Eigler. Do you know of other cases that are similar?
There is one very recently who was a very high-risk case. We didn't think that patient would make it, and the case went to coronary bypass, but we had to keep him on it for about 5 hours until the surgeons were ready. Everything went smoothly, very smoothly.
Yes. Now, let's just turn to the issue of intractable arrhythmias and the use of retroinfusion. This allows really to get a high concentration of antiarrhythmic substances where they need to be. Is that not correct?
That's true. Lars Ryden, who's working with us on sabbatical this year from Karolinska Institute in Sweden, has found that he can get 1,500 times more concentration in the heart muscle that's affected with the ischemia. So that he's been using metoprolol, which will reduce infarct size. We stand a great chance applying this to the human, this new principle, because we can get such high concentrations in the heart muscle. Before we had to flood them from head to toe, but now all we have to do is deliver a small, safe amount right in the ischemic heart muscle.
Elliot, that is really fascinating, but I understand that you've pursued the matter even further. And can you tell us a little bit about your thoughts about prevention of stroke?
Well, I think if we can get in within a 3-hour period following a cerebral thrombosis, we stand a good chance of maintaining that brain and prevent stroke from damaging this poor patient.
This is really a major breakthrough and a major application of an extremely important principle. Elliot, thank you so much for being with us. These are wonderful results. Now, in summary, I think we have a number of important things to comment on. One, that retroperfusion infusion is safe, rapid, and simple to perform. Second, that it reduces ischemia during angioplasty. Third, it has potential in acute infarction. And fourth, it suppresses arrhythmias with very little in the way of drug use. That's it for today. I'm Dr. Jeremy Swan. Join us next week for Cardiology Update.